the topic today is about periodontally enhanced orthodontics. And the concept is related to the way we periodontists can aid and support orthodontics. So let me start by moving the screen first, and we will, okay, talk about the lecture learning outcomes. So today I'm going to just mention few clinical scenarios of possible periodontal orthodontic collaboration in terms of identifying the role of periodontists in advancing the outcomes of orthodontic uh, care, and learn some of the indications or contraindications of some of the techniques periodontists do to enhance the outcome of orthodontic treatment. In general, the way we periodontists think about orthodontics and orthodontic care have shifted through the ages, especially in the last 10 to 15 years. The periodontally accelerated orthodontics fills a big list of procedures that we do, starting with concept of decortication or management of impacted teeth, soft tissue grafting, vestibular deepening, frenectomy, and placement of anchoring devices, all the way to optimizing the results after the debonding of the orthodontic treatment, or what we call the day after debonding. And usually when we think about that, we think about aesthetic crown lengthening in general. The last phase or the last type of collaboration is those complex cases that are not pure orthodontic cases, but orthodontics is just a component of a more complex treatment plan that is usually restoratively driven. So this relationship has evolved throughout the years. And with all of the advancements of IT and informational technology services, software and hardware that you are all not only aware of now, but you are practicing, you can see, especially during the Corona period, those last 9 months, how the reliance on online technology and reliance on contactless technology has evolved. And this is not going to go away after, inshallah, we get rid of this virus. I think technology is here, whether the ones we started to use before the Corona or the ones that are evolving now, they are here to stay. So when we talk about this relationship, we have to think about this shift in the referral base of patients. When we think about the orthodontic patient, the ideal one comes to mind, usually 12 to 15 years old teenager who visits the orthodontist with their parent to make their crowded teeth become more aligned. This was kind of the classic way that we looked at orthodontics, as a mono specialty kind of care. But things have changed and the patient pool have evolved. And most of our patients now that we see in periodontics or in implant dentistry or in prosthodontics or restorative dentistry are patients who are open-minded towards considering orthodontic treatment as part or a component of a more complex treatment plan, because the expected outcomes, their objectives are more complex. It's not about just straightening teeth. We have been seeing more and more adults in their 40s and 50s who are not only inquisitive, but also interested in obtaining ideal smiles with a healthy outcome. So again, this shift in referral base have reignited the importance of orthodontics in the restoratively driven treatment plans. And this kind of built more and more creative ways of dealing with orthodontics as a component of a bigger treatment plan. Let me start with what we are doing more and more now, which is enhancing the speed of orthodontics, or providing faster and more safer orthodontic treatment to patients who in the past were either taking too long or not even being considered as candidates. So the techniques to accelerate orthodontics in terms of decortication or orthodontics depend on few important factors. But the most important factor that we rely on is enhancing the osteoblastic and osteoclastic coupling activity within the bone, enhancing the bone metabolism in so many different ways that will cause the teeth to move faster, basically, and that is the bottom line. We call that phenomena the regional acceleratory phenomenon, or the RAP. And when we perform these surgical procedures, the RAP will initiate or allow this movement to be expedited and take care faster. The RAP depends on transient osteopenia around the roots, and this induces a rapid tooth movement within the bone. So two factors have to be balanced in order to achieve this ideal balance that will enhance the tooth movement very fast, which is reduction in the bone density and increasing the bone turnover around the root. And this will lead to resistance against the root movement, and thus the RAP becomes clinically effective or clinically relevant. Throughout the years, since 2003, 4, 7, then 12, 9, then 13, then 20, multiple techniques have been developed, and more advanced modifications have been taken place to reduce the trauma effect and improve the accuracy and reliability of the decortication of the bone to lead to tooth movement. But all of them depends on decortication of the cortical bone around the teeth that are involved in in the movement, or the teeth that we are desiring or planning to move quickly. It's very important to point out that when we talk about decortication and corticotomy, we are not talking about osteotomy. We are not talking about moving teeth in blocks. We are talking about creating calculated and well-designed perforations in the cortex to reach the cancellous bone. So this kind of trauma is what will cause the RAP to take effect. So this is very important, because we are not talking about a more traumatic experience that the patients used to have. In terms of history, our techniques have evolved. Since 1978, the concept of osteotomy was developed. Then we moved to corticotomy, then decortication. But the point is, nowadays, we are not really doing all of these classic school techniques that are considered kind of a little bit aggressive. We can reach the same outcome, or sometimes in certain situations, even better outcomes, by going less and less invasive. Wilco brothers, one of them is a periodontist, and the other one is orthodontist, were a pioneer team of the Wilcodontic decortication technique, which they called accelerated osteogenic orthodontics. And the concept is a combination of creating these perforation lines between the roots that penetrates the cortex and reaching the cancellous bone, and then adding a bone graft to cover all of the created defects or accelerated defects. Again, the techniques has evolved. This is how we started do it. This is actually, I started doing decortication back in 2007. So, and this is what we used to do. It was very traumatic, ended up with a lot of edema to the patient and a lot of pain. So it was really hard to tell the patients that this is something that can enhance treatment with low morbidity. So at that time, we used to do it only for sites that we really had a lot of resistance in terms of movement, or when we have a major case that needs to end up very fast. But we were always shy from promoting it to many patients. But if you look at the data, it was really at that time very impressive. We were able to expedite by 2 to 3 times the movement speed. We were able to avoid sometimes orthognathic surgery in small shallow anterior open bites, and do intrusion and extrusion in much faster rate. So we moved to a less invasive procedure, which is the POW, which is periodontally accelerated osteogenic, using less traumatic experience of the patient by not reaching the apex of the root, but just doing interdental kind of decortication between the roots. And we will talk a little bit about how to do it in a less traumatic way, but the indications in general are wide, and they increase with time. The Wilcodontics, or the decortication techniques, are really very effective when it comes to adult patients. As you remember, movement of teeth due to the reduced remodeling potential of bone becomes less and less with adults, and that's the orthodontic treatment becomes challenging. So decortication is a very, very good tool in those patients. Again, when we are running short of time or we want to finish fast, even in younger patients, even in teenagers who don't have a problem in moving teeth, but you want to finish fast, they are very, very good candidates for decortications. We will see a couple of cases where we have difficult movement sites, resistant sites, that the teeth just stopped moving. And probably many of you have seen some of those cases that end up with residual spaces, especially in the mandible. Sites with compromised roots already due to resorption, due to prolonged orthodontic treatment or other reasons, poor crown to root ratios, where you don't want to apply a lot of force on the roots. All of these are good indications to do decortications. And finally, patients who already have experienced periodontitis and reduction of periodontal bone support. And Dr. Sahar and I, we were talking about such cases just before we entered the room. And those are really good cases to manage with the decortication process. So all of these are interesting cases that we look at, and we measure them case by case in terms of case by case basis. We never do any kind of orthodontic treatment if the patient have unstable periodontitis, or if they are going through major attachment loss, major recession, because we need a lot of soft tissue availability, and we need low inflammatory rate to enhance the movement and reduce the risk of failure. Like all periodontal surgeries, patients who are uncontrolled diabetics or have immune problems, or any patients with bone metabolic disorders are contraindicated for any major periodontal surgery anyways. So that brings the bill for bisphosphonates, especially patients who are chronic users of bisphosphonates, patients with active caries or endodontic treatment that is still incomplete. There are still a lot of indications also or malocclusion cases that cannot be solved by non-orthodontic procedures. So those are not really candidates for our procedures. So those are summary of the lists that we really think that we do not get a lot of benefit when we do decortications for. But in terms of the advantages, we get a lot of reduced treatment time, and that's by itself a very, very good tool. We improve the periodontal and the bone support because we simply add grafts, and many of those cases you'll discover when you open the flap or when you cone beam that they already have natural dehiscence or fenestrations in the roots, and by doing the grafting you are enhancing the periodontal phenotype, whether soft tissue or hard tissue. We have less risk of root resorption. We have less risk of relapse. And this is very, very interesting. And we will talk about it in few slides, why those cases don't have, we still have relapse and you still have to do retention, but the risk and the amount of relapse is much, much lower. And the patients are happier. The disadvantages, however, that this is an extra surgery, so extra surgical morbidity and extra surgical costs are included in the problems. If it's not done right, there is still a risk of surgical damage to the roots, surgical trauma to the roots if it's not properly done. So we went through a lot of guidelines throughout the time, as I said, about this technique, and we moved from major removal of cortex to less and less, I'm not going to call it destruction, but less and less invasiveness in the procedure, because our tools have evolved, our understanding have evolved, and our ability to, again, create the same wrap effect, but with lesser trauma have become more and more clear. So if you look at how we started in 2007, again, we went around the root, creating these crevices, removing the cortex in a continuous pattern, all the way circumferentially, and sometimes buccal and palatal, depending on the direction, not only in buccal direction. Then we started moving towards just causing decortication effect or wrap effect only close to the root that we want to move faster. And we started with defects, then we started just doing small perforations, and now we moved even further to just using the piezo scission, and we will talk about it in a while. This is very highly recommended reference for this lecture. It's published in Clinical Advances in Periodontics. This is a checklist for what is the best tool or what is the best technique we could use in order to enhance orthodontic movement by periodontal surgery, depending on the patient bone and gingival phenotypes that are available. We can decide which of the techniques we can use. So I highly recommend this reference. If somebody likes to take a snapshot of it, this is really a worthy reference. Now, most of the techniques that we use now rely on cone beam. We started again in the 2000s when cone beams were not available. So we had to use 2D radiographs and our palpation skills and our experience. But now there is no excuse for us not to use cone beams in planning decortication, in planning orthodontics. Even orthodontics as a specialty have evolved into more and more computer-based approach to cases and planning through computer, even computer-generated orthodontic appliances. So CBCT became a very, very important tool. And for our indications or our procedures, we always do it all the time before we tell the patient that we can do the procedure for. Now, let me show you one of those resistance sites. And if you go back in memory and you look at the cases, you remember it's always this spot. It's usually a first molar that have been lost long time ago, or a premolar that was lost during childhood. And then the 7 or the second premolar cannot close the space despite the forces that have been applied, is just resistant to movement. And many, and those spaces are too small for an implant to be placed. They end up with unstable occlusion, and the orthodontists become frustrated, and some of them will just debone the patient with such residual defects. So in these situations, this is where you can think of our technique as a very handy technique and very localized. So what we do usually is we just open the area and we do these perforations that you can see in this image, just to reach to the bleeding surface. The bleeding usually means that we have reached the cancellous bone, and this is our sign. And you can see the mesial root of the molar even. So this tells you how thin the tissue is. And this is one of the reasons why these teeth are not moving, because there is not enough alveolar bone for the root to move into. So what we do here is a combination of wrap and also building the ridge to allow the movement. We always open the sites that are going to be moving. So if we are moving, for example, the incisors or the laterals, or in this situation, the premolars and the canine backward, distally, we will open the space where each and of these teeth are going to be moved. So after we do the decortication again, in this situation, we need to do bone grafting, and for two purposes: to enhance RAB, to improve the phenotype of the bone, but also to cover the exposed root of the incisor. And in those situations, we get very, very nice results. I'm going to just point out that we don't always use a bone graft. In cases that we have adequate width of the bone, we don't have a problem with the phenotype of the bone, we have enough volume of bone to allow the root to move in, we don't need to do a lot of grafting. And in those situations, we only have to use piezo inserts that will just create the wrap, will create only the trauma, and allow the roots to move without a risk of recession or dehiscence, etc. So the piezo scission, which is a technique that invented in or developed in Boston by Dr. Debart, have been used for the past 5 or 6 years. And it's a very, very successful tool. Again, if we don't want to graft bone, there is no need to graft bone. And it does the effect of the wrap without creating a lot of damage and destruction by using the high-speed burrs that we use. Piezo surgery was invented back in 1988, so it's nothing new. Regardless of the machine that you use, many of the inserts are similar and they are alike. But the hardness of the power of the piezo have allowed us to use very, very thin inserts. You're talking about 0.2 millimeter width, which is extremely narrow. So when you look at the roots that we do decortication for and the small spaces of the periodontal ligament between them, you can appreciate how important this technology has evolved. When it was first proposed, it was proposed to be done even without an incision. I usually don't recommend that because that will create a lot of trauma to the soft tissue. So I do very, very small linear incisions that allow just the insert between the roots to go in. And we just go in again. If you look at the inserts, they have actually they have dots to tell you the distance that you penetrate through, and we just go beyond the cortex to create those lesions, and we're going to look at this. This is one of the cases that was done by one of my excellent residents, and I love sharing my residents' cases because they take excellent photos, but also because they do great job. This is one of the cases, and actually, Dr. Abdelmajid and I have presented this in a competition, and he won a very nice award for the series of cases. You can see how these complex cases have evolved. Again, one of those cases done as a collaboration with a post resident, and you can see and ortho resident, and those cases with not only persistent spaces but also crowding can get expedited care very, very fast in those situations. So this is the case radiographically, short roots. If you look at the premolars, a lot of risk factors for classic orthodontics. And this is why the orthodontist could not just apply all of the force. So when we look at this tree that we talked about, the decision tree diagram, this patient have thick phenotype of gingiva and have thick phenotype of bone. So in these situations, there is no need to cause a lot of damage to the bone and put a bone graft. In these situations, it's just good enough to create these very, very thin sluiceways by the piezo and just create this wrap trauma to allow the movement of the teeth faster. Now, this is what I was talking about when we talk about the thickness of the tip. In these situations, we don't, first of all, have to go to the apex. And secondly, you can go in very, very narrow spaces without creating a lot of trauma. And those are the cases that get very, very nice outcomes. And you will be surprised. This is how it looks in just a few weeks. The space is almost closed. The crowding is still not totally resolved, but you can see that in less than 3 months, this patient is going towards a lot of improvement without really creating a lot of damage. Another case, 20 years old patient, again, if you look at the lower molar, and you can see the persistent space instead of the second premolar, no movement, resistance for months. Again, the decortication becomes the treatment of choice. In this situation, there was no need for bone grafting, so just a linear incision, inserting the tip inside, just a couple of sutures, and applying heavy forces. And this is the key of wrap movement. You cannot wait for a month. The activation should take place within 72 hours to 10 days. Sometimes even, I mean, 10 days is a little bit even too long. In those situations, 72 hours to a week, and heavy forces are applied. And you can see within 8 weeks, the space have been totally closed, not only clinically, as you can see, but also at the radiographic level. However, it's not a magic solution. There is no magic solution for everything. One of the drawbacks of piezo-scission that the wrap effect coming from that is transient. It does not last more than 3 weeks maximum. So in cases where the spaces are very wide, it needs to be repeated more than once for the site to enhance the movement. Every time the orthodontist feels that the force is not causing the movement anymore, the patient is sent back to us and we will do the piezo-scission. But this is usually only for big spaces. One of the things that we help orthodontists with is using the anchorage devices. In the past, we periodontists and maxillofacial surgeons, we used to do the mini screws for the orthodontist, But for the past at least 5 or 6 years, I have not get any mini screw case. Now orthodontists do their mini screws, but we are still needed for more heavier anchorage devices like mini plates, the mini zygomatic plates, or plates that are anchoring devices in the bone of the mandible. And those are cases that are very, very interesting, or the palatal mini implants to expand or to cause heavy anchorage load instead of the classic mini screw that does not give enough load for those patients. So mini plates are usually a good tool, although they are very limited in use nowadays yet, because of the invasiveness of placing an axis. But this is one of the classic cases of advanced periodontitis, 30–40% of bone loss, excellent oral hygiene after years of negligence. Patients usually when they are 40–45 discover, oh, I need to fix the problems that I ignored for years. And if you go with classic orthodontics in these situations, it's very risky to move teeth. This is one of those cases where the patient is ending up with a lot of spacing. And this patient needed also bone grafting and needed periodontal surgery. So the decision was, this is a case of one of my colleagues who is a senior consultant in periodontics, Dr. Jassim Abdel Masih or Al Masih. And this is a very, very nice case, but he just combined a combination of periodontal surgery, periodontal bone grafting with mini plates all at the same time. When I would like to share with you how it looks like at 2 weeks, and you look at this and say, whoa, well, you see this kind of tissue healing because there is bone loss, and this is a periodontitis history case. So you have to be capable of managing those cases. And if you look at the photos, you can see some of the traces of the bone graft I don't know if you can see my mouse, but you can see these white particles of the bone graft that was placed in few locations. But you can see also the heavy anchorage that comes from the zygomatic implants. But the case evolved with time, and this case is still under movement. But you can see how all of the maxilla have been retracted to the back, and the occlusion is closing, and the tissue is filling as well. This is a classic case where a combination of ortho, perio, prosto are going to finish the case. So after the completion of this ortho movement, it's not enough to send the patient home, because they are not here to just have aligned teeth. They are here to have perfectly healthy, good looking smile. So biomechanics of non-tooth anchorage devices are one of the important tools that we periodontists can help the orthodontics explore and use. Again, in many scenarios that we use for anchorage. Even sometimes implants can be used for that. Now let me move to something else, which is the restorative demand. So again, as we started with, patients who come to orthodontic clinic have not been the same for the past 10 to 15 years. This is one of the lovely cases that my colleagues, Dr. Hakam, Dr. Amr, and Dr. Isam have worked with me on this one. My role as a periodontist was very small role, but this is a case of amelogenesis imperfecta. And when you look at this lovely young lady, you think, oh, this is a smile of a 50 years old. But actually, this is a very sweet lady who is just unfortunate to have this amount of attrition. And even radiographically, you can look at the abnormal appearance of the enamel and dentin. So in this situation, the decision was to build a process of a treatment plan. We needed to expose those teeth, but at the same time, we would have exposed them. They might be lost immediately to attrition again. So a careful plan was designed to build the smile of this patient, starting from the maxilla to the mandible, through different phases that involve periodontal crown lengthening, orthodontic treatment, and restorative phase. But the sequence in this situation was a little bit different, because we needed the orthodontic treatment to start the extrusion of some of these roots, but the orthodontists need periodontal crown lengthening just to give them access. So the crown lengthening in this situation was not for aesthetics. It was to grant access for orthodontic treatment. So these are one of those situations that we just gave the patient enough tooth structure so the Restorative dentists can do proper root canal, just build temporary provisional crowns that will allow the anchorage of the orthodontic devices and the orthodontic treatment to start. And if you look at the level of the gingival margins, you can see the improvement in the gingival margin level through migration of tissue. So in this situation, we did not only help the patient in terms of alignment of teeth, but the orthodontist in this situation helped the gingival tissue to reach a certain level of aesthetic outcome. Then the patient suddenly disappeared. This is one of the old cases that we have done. And she came back years later and she had just the buildup again. Things are not really bad at that situation in terms of maintenance of those teeth, but we had to give her something better. You can see the malocclusion that took place, the open bite, because it was an incomplete treatment for certain reasons. Anyways, the case was then redone prosthetically to enhance the aesthetic outcome of the smile. And I stopped working with this case with the maxilla. Some patients are just happy with that, but I hope that she came back to Amr and Hakam to finish the mandible. But this is a very, very interesting case. Now we get to one of those cases that I call what to do after debonding. Another young lady who did not have optimal oral hygiene during orthodontic treatment, and you can see the hypomineralization and the gingival enlargement. But this is a patient who is not happy. Debonding took place, teeth are aligned, but this is not the way that a patient would like to look like. Usually, when patients come to me after debonding, I never make a decision about the aesthetic planning of the case. I wait, I do the scaling, polishing, I put the patient on chlorhexidine toothpaste to reduce the inflammation and to allow the tissue to become a little bit more fibrotic. Then I do re-evaluation. I look about a month later, 3 to 4 weeks later, to the tissue, how the edema have resolved, and how is the margins are going to end up to be stabilized. And then we decide how to move with aesthetic crown lengthening or aesthetic crown lengthening within with veneers. But usually those cases in general, most of the ortho cases that I've seen after debonding will require frenectomy with crown lengthening, because a lot of these frenum attachments are just either junctional or gingival. So put in mind when you tell a patient about possible crown lengthening after orthodontics, I don't know, because usually they end up with, especially the cases that end up with maxillary proclination of teeth, they end up with shallower vestibule, or they end up with really minimal amount of attached mucosa. But you have to be careful when you plan the case that frenectomy in many of those cases will be important and essential and considered as part of the treatment plan. Now, the position of the frenum and the timing and the treatment plan depends on when should you do the frenectomy. Sometimes we do it with the crown lengthening, sometimes we do it after debonding, and for a few cases, we do it just before debonding to prevent diastema from taking place. So usually the timing of frenectomy, I'm not really too religious about it. I respect the feedback from the orthodontist, but I always look at it when I want to do the crown lengthenings for ortho patients. Sometimes we do it during the crown lengthening, and sometimes again we do it shortly after, especially if I'm going to be using laser. It's very, very interesting to talk about those cases after orthodontic treatment. Post-orthodontics, I find very, very hard to reflect the tissue, because the soft tissue, that is. If you look at those images that you can see the bone, and you can see all of these striations on the bone, and those are the attachments of those fibers that have been rotated and derotated. And if you look at the level of the cement to enamel junction, you can appreciate that the cement to enamel junction is almost touching the bone, which in this situation just should tell you that simple gingivoplasty or gingivectomy or whatever soft tissue modification alone is not going to be enough to give this patient a long-term good crown aesthetic outcomes. So most of the post-orthodontic cases that I do end up with osseous surgery. So gingivoplasty, or what some people call gingivectomy, is most of the time is not good enough for short-term, for long-term aesthetic outcomes, and usually they end up with relapses. I'm just going to tell you that I find it challenging, and usually I go with sharp dissection sometimes with those cases. So don't try to rush yourself when you are reflecting a flap in a post-ortho crown lengthening. And again, look at that. Because of the intrusion, the cement to enamel junction is just there on the bone. So imagine that this patient might get a veneer later on. You will just be putting that veneer on bone and you will end up with a lot of inflammation. So that's why bone adjustment, osteoblasty, and osteotomy is important. The other thing is you can look at these striations and you can see this is one of the cases. This looks like a very, very simple case. And this is lovely lady just ended up with orthodontic treatment with nicely aligned teeth, but she's still not happy with the final outcome. And you can see again, when we reflected the flap, we have to do osseous crown lengthening to prevent the relapse of the tissue because the cement to enamel junction was just too close after the orthodontic treatment. Just simple covering, suturing, etc., crown lengthening, and you can see the difference. Just a very, very simple technique. But when you plan crown lengthening on patients after ortho, again, consider that most of those cases are going to end up to be flap cases. So we go back to this young lady, and again, flap was opened, and you can tell the difference between the enamel that was not exposed due to altered passive eruption and the enamel that was bonded. And you can see why this patient was not happy with the outcome. So all what we did in this situation was just to give her enough tooth structure to enable the restorative dentist to place sets of veneers. So osseous crown lengthening is essential for successful post-ortho crowns and veneers. Don't ignore that, and don't think that simple gingivoplasty is going to solve any complication after ortho. And this is very important, especially for patients who need to know prolonged treatment plan, including the cost of the treatment. This is another lady, 39, 40 years old. She went through 3 years of orthodontic treatment, and then the orthodontist just told her, oh, we're done. We cannot go any further. This is it. We're going to debond. So imagine yourself instead of this patient. Imagine the dissatisfaction, the anxiety, the upset feeling. And in these situations, again, ortho is just a component of the treatment. You cannot consider ortho as a solo treatment anymore, especially among adults. So this patient went through a treatment plan by a restorative dentist because that's how it's going to end up to be actually. This case was referred to me. I analyzed it in terms of crown lengthening potential. You can see the tubercles, the thin gingiva, all of this process. You can see the pigments, the asymmetry. So all of these notes have to be planned in advance. This patient went through depigmentation with laser and then went through crown lengthening. And this is one of the side effects that you can see here. I traumatized the bone during the process of depigmentation. I think the tissue was too thin for the power I used at this patient. It was a very valuable lesson because this scar took about 2 to 3 months to heal, and we were waiting to finish the case. So I did the depigmentation first, then I did the crown lengthening for the patient. And you can see that it's not only about removing from the bone around the teeth. In this situation, we have to do osteoplasty. We go all the way and clean up all of the tubercles to make sure that the tissue is thin afterwards, and we can achieve the objectives of the restorative treatment plan, because this is what we are looking at. And the outcome of this case was just one of those great ones. I was very happy to see this patient happy later afterwards. So ortho alone cannot fix this patient problem. Perio alone cannot fix this patient problem. I'll take a sip of water, I'm sorry. It's a multi-approach or it's a team approach process that fix this patient problem. We come to phrenectomies, and phrenectomies are very, very interesting. They are challenging if you look at them because it's not only about the procedure itself, but it's about the morbidity. It's about the age of the patient. Many of those young kids are 8 and 9 years old, and they don't want to have a lot of bleeding. They don't want to have to go through surgery. They just don't enjoy it. But the point is, what is the relationship between a diastema and the maxillary frenum. Is there is a true relationship? Clinically, it looks like there is an association between large frenum attachments and penetrating frenum attachments and deep frenum attachments between maxillary central incisors and persistent or relapsed diastemas. So don't forget that frena is part of the oral cavity. It's a post-eruptive remnant, and it connects sometimes deep to the palatine papilla, and those are very challenging. This is a classification of frena in the maxilla, and this is the only classification that is still used, actually. It's a very good one. There are 4 levels of attachment of the frenum in the maxillary central incisor area. Mucosal means it's apical to the mucogingival junction. Gingival, it means it is at the mucogingival junction or a little bit more. Papillary means it's in the interdental papilla between the central incisors. And papillary penetrating means it goes all the way to the palatine papilla. And those are very, very challenging. And you can see that frena or freni can come in different sizes, different locations, and their management is challenging because in those situations, they are part of the aesthetic struggle. So it's not only that it's an orthodontic challenge, but it's also an aesthetic challenge because you don't want to scar an area that will look as a scar when the patient smiles. The timing of the frenectomy depends on the clinical presentation and the treatment plan. I usually leave it to the pediatric dentist and the orthodontist to tell me what is when is the time to intervene, because many of those cases will resolve by themselves during the development of the anterior or the premaxillary vertical growth during growth of the child. But in certain situations like the one you see when you have a huge size papilla that will prevent the meeting of the central incisors, sometimes we have to intervene. You can see how, for example, you can see the upper left one. This is a classic penetrating, papillary penetrating frenum that goes all the way to the palatine foramen. And those will definitely interfere with the closure of the diastema between the central incisor. So again, they come in so many different sizes, and some of them, although look narrow, like this one on the right, lower right, this one is not only papillary, but also penetrating, and you can see its mark on the radiographs. Sometimes we do the frenectomy during orthodontic treatment just to allow the movement of the teeth. This is one of those situations where we would not wait till the end of the ortho. We have to do it to allow the movement of the teeth. For the past 10 years, most of my frenectomy and frenoplasties are being done by diode laser. I don't use surgical blades unless the diode laser is just not ready in the room for a certain reason. But it's very, very predictable technique because the devices are programmed for soft tissue procedures, and they just do frenectomy in a very, very nice outcome with minimal bleeding, minimal morbidity, and very, very high dexterity in cutting. And this is very important, especially when we talk about papillary ones between the central incisors. Like this case, for example, imagine doing this coronal crest of the frenum by a blade. It can be done, but it's not going to be as accurate and as surgically, let's call it without surgical trauma as when we use a laser, because you can see the depth of the penetration, and you can see that the laser just went after that and kept the papilla intact. And this situation, this patient had a persistent diastema that keeps relapsing after orthodontic treatment. So we went after that papilla to close the space. And you can see just by removing that frenum, the diastema has just closed by just having the patient wearing the retainer. So you can see how effective frenectomy became in this patient. The only issue with laser is that the healing is slower than the surgical blade use. So usually I give the patient 1 extra week of healing instead of 1 week. It's 2 weeks for proper healing. So this is the patient again, and you can see that the diastema just closed with the retainer. You can see those big cases, and you can imagine doing a surgical procedure with a lot of bleeding and a lot of swelling afterwards and morbidity. And the laser will just cruise through this process with minimal scarring and migrating with the frenum all the way back to make it mucosal frenum instead of papillary penetrating frenum, with very, very nice outcome and without major loss of the interdental papilla. We move to the next phase. I hope I'm not boring you guys, but this is very, very dear topic to me, because I discovered when I used to deal with some of my colleagues in orthodontics that orthodontists usually don't study about implants in their specialty training, except that it's part of a complementary phase of treatment. So I'm just going to give you a few of the tips that orthodontists need to pick up, especially in the area of the lateral incisors with congenitally missing spaces, because we always suffer from these complex scenarios where the patient went through orthodontic treatment and got debonded, and then because the clinical space of the lateral incisor is adequate, and then you discover that the position of the bone or the roots is not suitable for an implant placement. This is one of those situations. Actually, you can see at the lower right image, and you can see that the patient have two missing incisors, and you can see that the clinical space here, or not the clinical, I mean the reconstructed space for the incisors is adequate. But if you look at the position of the apex of the root, it's totally in the middle of the ridge. So those cases cannot be treated with dental implants at all after debonding, unless retreatment has been done again. So to avoid this, it's very, very important not only to focus on the clinical dimensions available for the implant, but also for the radiographic dimensions related to the root itself. The position of the roots of the adjacent teeth is crucial to allow implant placement. So I made a small table here just to explain to my orthodontic colleagues that for ideal placement of an implant, we need a distance of 1.5 millimeters between the implant surface and the adjacent root. And this distance is crucial to provide an ultimate aesthetic and functional relationship between the tooth and the implant adjacent to it. However, in the anterior maxilla, especially when we work with incisors, especially in our region, you can see that many people have thin phenotypes, and we end up with acceptable level of 1 millimeter distance instead of 1.5 millimeter distance. So if you look at this image, this is what I mean. 1 millimeter on both sides is the minimum acceptable space between an implant and an incisor, or a root of an incisor, to preserve the papilla and to allow a good healing of the soft tissue to give a nice aesthetic outcome, and at the same time avoid damaging the roots. So usually we place the implant in an ideal position. We try to avoid ending up with loss of papillary height. So again, 1 millimeter is the minimum distance, but how can we refer to this clinically? I'm going to just share with you. Now, you need to know that the narrowest available implant diameters range between 2.9 to 3.5 millimeter, depending on the company of the implant and the manufacturer. So it's very important for orthodontists to know which implant their periodontist or surgical colleague is using and what is the narrowest implant they can place. And based on this, they can do the calculation of how much space they need to create between the roots. So let me give you this table here and explain to you my point. For a 2.9 millimeter implant, we need to create a space between the roots that allows the 2.9 millimeter implant and 1 millimeter on both sides. So you need a minimum of 4.9 millimeter to be able to place a 2.9 millimeter implant, which very, very few number of people use. For example, I use a 3.3, my manufacturer uses 3.3 millimeter implants. So that means that I need at least 5.3 millimeter space between the roots to be able to place an implant. And that is giving that I'm doing a perfect surgery without any deviation, with a perfect guide. So you are not giving me any space for an error. So if you want to give me a space for an error to give me a breathing point, give me 1/2 millimeter on both sides extra. So I will add 1/2 millimeter on each side, and I will say 3.3 millimeter plus 1.5 from mesial, 1.5 from distal, and that will give me 6.3 millimeter space. So for an orthodontist to say that I give you enough space to place a narrow implant, you have to give me 6.3 millimeters between the roots of the two adjacent teeth to the implant space. Those are some of these interesting cases. And this is what I'm talking about, the evolving of ortho restorative interaction through computer generated ortho treatment have created a lot of potential of collaboration. This patient is missing the lateral incisor, and just using the computer generated ortho treatment, the space was created and an implant was placed. So if we did not measure, look at this very, very tiny space. It was just on the edge, beyond my comfort zone. We managed to do it. It managed to end up to be a nice, because this is a 3 millimeter implant for this manufacturer. And the case ended up to be a very, very, very nice case. But if I could not do that placement, if there was just another half millimeter margin for error, it would have been much, much easier for me to avoid that problem. So this is one of those nice cases that collaboration have taken place. So always take a cone beam before debonding if you are in this critical situation. Look at the roots. We don't only now are satisfied with cone beams, we create 3D models to see the 3D relationships between the roots to be able to place an implant. This is one of those cases that we created a 3D model and then 3D surgical guide, because the root distance was extremely narrow again to create a space, but the outcome was, again, one of the good outcomes in these situations. And this is after Dr. Hakam, I think he did the temporary provisionalization, pushed the tissue and rebuilt the gingiva. But you can see that the collaboration is very, very important, and understanding that we need a minimum distance to placement of the roots or of the implants is very important. Cone beam 3D radiography keeps coming back and forth. Impaction, 90 or 85% of the impactions are palatal, 14% are buccal. But to be accurate, especially in the aesthetic zone, it's very, very important to take a cone beam so you go surgically. This is one of the challenging cases that I have done. And without taking a cone beam, I would have never guessed the relationship between these teeth to be able to design with the orthodontist the proper plan to be able to move these teeth in a proper relationship. When we have buccal position of the implant of the canines, it becomes challenging, because it's not only that we want to move the canine properly, but we want to maintain good amount of attached mucosa and keratinized mucosa around it. So usually in these situations, we end up with laterally positioned and apically repositioned flaps to create keratinized mucosa around the erupting tooth. So it's not a matter of just a simple incision or a laser exposure, because most of these usually end up with lack of keratinized mucosa. So it's very, very important in the facial impactions of canines to rebuild the keratinized mucosa and at least build a 2 millimeter band around the canine. Some exposures really make me happy. This is a young, lovely 9 years old lady that those centrals are just don't want to move. So all what I did in this situation is just get rid of that thickened component of the gingiva slightly from the palate, and just pushed it facially to build keratinized mucosa facially, and those teeth just kept pumping out. And this is, her father sent me this because this was during the quarantine, and her father was just so excited, and he kept sending me those photos every now and then to see how his daughter was so happy with this simple exposure. This patient will need frenectomy eventually to make sure that the closure will take place. Sometimes we get those cases again that we discover that the phenotype is thin. The patient needs better phenotype before the teeth are pushed facially. And this is one of those situations that we used an allograft instead of going with a connective tissue graft or free gingival graft. And you can see that the phenotype just evolves when you do this. This can be done through tunnel technique or through regular technique. But let's avoid negative biomechanical effects on the periodontium. Let's make sure that orthodontic treatment is building the periodontium instead of really damaging the periodontium through certain mistakes. Those are some of the failed planning that lead to the failed outcomes, where teeth are really with their periodontiums are in hazard. I'm guessing, anticipating one of the questions is, but we hear that proper orthodontic treatment could enhance periodontal treatment and sometimes get rid of infrabony defects. And that is true if it was properly done. But poorly planned cases end up with a disaster at all levels. Like this case again, not only resorption, but the canine did not come out. Everything moved to the wrong direction. This is one of those active periodontitis cases. You cannot do ortho on active periodontitis cases because that will lead to disaster and failure. This is a very important position paper by the American Academy of Periodontology, and it just gives you the sequence of when should you intervene orthodontically in a patient who have periodontitis. How long do you have to wait after surgical treatment, whether patient need only scaling and root planing or they need scaling, root planing plus surgery. So the average waiting time varies between 3 to 6 months for non-surgical cases, all the way to 1 year in cases that require bone grafting. But those are the advanced cases of periodontitis. And if you like this paper, I can send it to you again with the other one. But this table is, this graph is a very, very nice graph to help you make a decision of when should you send a periodontitis patient to orthodontic treatment. Again, this is the graph again. And if you look at what we see, it's always about maintenance and stable periodontal status. Reduced healthy periodontium can receive orthodontic treatment. This is one of the cases of Dr. Siebert, I guess from one of my friends who was his student. This is a tooth with an infrabony defect that was planned for extraction, and apparently Dr. Siebert convinced the patient to go through a process where they did the uprighting with orthodontic treatment with the orthodontic wires, and after the uprighting, debonding happened, and the tooth was taken as a histological biopsy. Dr. Siebert died a long time ago, and this case was done in the 70s. You can never get an IRA approval nowadays for such a procedure. But the interesting thing is that you can see the new bone formation in the intrabony defect that was created. So properly designed orthodontic movement, yes, can help fix the part of the periodontal problems. And this is a bone with Haversian system, as you can see. These are very, very rare and special slides. So by this, I hope I finished. And oh, okay, perfect timing. As promised, Dr. Sahar, I finished the hour. I hope I did not bore you guys. I'm ready for any questions. Thank you very much.
At all, Doctor. Thank you very much for this informative and very interesting lecture. I myself, personally, I have a question for you, Doctor, if I may ask. Could we use decortication or wrap for cases where we need to make intrusion or intrusive forces? And
yes.
If it works, if it's okay, where could we direct the decortication? Could we do it on the apical parts of the root? I don't know, of the bone.
Yeah. Those are the tough ones. Intrusions work, actually, they work nicely with the wrap, but you have to be a little bit more apical in your flap or your exposure or your piezo-scission to go at least 2 millimeters to 3 millimeters beyond the root apex to be able to enhance that movement. Intrusion, as you know, are very challenging. But we have multiple options for intrusions. We could go with wrap, could go with mini screws or with anchoring plates. There are multiple solutions for intrusions that prevent root resorption. But yeah, it does work.
So it wouldn't affect or jeopardize like the support or the, I don't know, the bone support of the...
Usually we are not worried about the bone support as much as the pulp necrosis if you compromise the vascularity at the apex area. So that's why you have to leave the 2 millimeter safety distance. But that leaves the question is, am I too high? Especially this is an issue in the posterior mandible more than anywhere else. Or in the posterior maxilla, for example, when you want to do maxillary impaction, because you are close to the sinus sometimes, or you might end up in the sinus. So instead of decortication, you might end up with zygomatic mini plates or mini screws.
Yes, yes. Okay. So let's move to the questions. The first question, doctor, why is it a contraindication, the wrap or decortication in bimaxillary protrusion?
It's not contraindication because it's harmful, but because it does not give the benefit. And bimaxillary protrusion needs orthognathic intervention. When we talk, I showed you that table, but I moved very fast. When we talk about impaction or intrusion, you're talking about with wrap, with decortication, you're talking about probably 5-6 millimeters correction. But when you have bimaxillary protrusion, usually that's the amount of correction needed is much more than that. You're talking about sometimes 15, 20 millimeters and sometimes even 30, 40. So it's not a matter that it's harmful, but it will give false hopes for the patient.
Okay, so what is your preferred technique for exposure of buccally impacted canines and an apical repositioned flap or something else?
Well, I have a lecture called canine exposures because canine exposure actually is an art by itself. And especially the buccal ones, most of the time I go with apical reposition, but the key with apical reposition flap around impacted canines usually is not really the apical fixation itself, but the incision design. Because sometimes if you just open an incision around the canine and try to apically reposition it, you will end up with an area that have thick amount of keratinized mucosa and area that has no keratinized mucosa. So the incision itself should be done in a way that resembles the laterally positioned flap of Groppi, if you remember that. So I usually design the the exposure of the labial canine, especially with thin mucosa, as a laterally positioned flap design. And that will allow me to rotate the mucosa and apically reposition it at the neck of the canine. But yes, I go with apical reposition. Sometimes I go with lateral papillary reconstruction, but most of the time it's apical reposition.
Okay, for how much depth should we go in decortication?
Usually I say till you get the bleeding surface. So if the cortex is thick, like for example, sometimes at the premolar area and the mandible, sometimes some of these cortices, and you can see it on the cone beam, exceeds 1 millimeter and reaches 1.5 or sometimes 2 millimeters, especially for those patients who take a lot of vitamin D. But in those situations, you have to penetrate to reach the cancellous bone. Most of those cases, however, my experience is you reach cancellous bone by 1 millimeter. If you remember the paper done in University of Jordan, it was done by a group. I'm trying to remember the names. منهم Dr. Murad, Dr. Sandra. Most of Jordanian population have thin buccal bone plates. You are talking about 1 millimeter or less, 80% less than a millimeter. So usually when you penetrate, you don't need to go more than a millimeter at maximum. So don't be too aggressive. In the past, we used to go really aggressive and we used to go buccal and palatal. We don't do that anymore. We just want to initiate that trauma. So usually I go like 2 millimeters maximum. So 1 millimeter cortex and penetrate 1 millimeter into the cancellous bone just to initiate that trauma and make it last for 3 to 4 weeks so the orthodontist can really apply enough forces to move. The other thing I failed to mention is patients who are undergoing decortication are not seen by the orthodontist every 4 weeks, but they should be seen every 2 weeks to keep the wrap movement going. And at the same time, because the teeth will move so fast that if you let it go for 4 weeks, the effectiveness of the activation is lost at 2 weeks usually. So that, and this is why the time is cut in half usually, 2 to 3 times faster, because the patients need to be seen every 2 weeks instead of every month. So it's also important to make the patient aware of that you'll be coming every 2 weeks. Can you do that?
Wow.
And the orthodontists need to be aware of that. You have to see this patient every 2 weeks. You're not going to take a vacation for 2 months after I do this procedure. These things are technical but important.
Okay, what is the best treatment plan for a patient with amelogenesis imperfecta and need ortho from a period point of view?
This is I shared with you this case, and those cases are very few, so I cannot give you a blanket statement, but just out from experience with some of these cases that we all deal with, the problem is the fast attrition. The more surface you expose and you leave uncovered, the faster the loss of the tooth structure. So my advice would be, plan the case in a way that will immediately lead to at least putting something temporary on the crown so it does not get lost. Like the case that we shared, the point was just to immediately restore it, even provisionally, to prevent attrition from taking place and to maintain that tooth structure till the treatment is completed.
يعني خطر على بالي قبل شوي سؤال انه الانتيريور المانديبولار anterior area بتخيل يعني it needs the most يعني you need to go بالدبث اكثر شيء صح؟
In terms of
يعني when we do the decortication بمنطقة lower anterior mandible I assume انه we need to go the deepest يعني we need to go like for 2 milli or more. Could we need that يعني
Look, I never do decortication without a cone beam. يعني, so that to make it easier for all of us. Yes, the mandibular body is very wide, apical to the roots, but not usually at the root area. In contrary, many of those root areas, if you look at the cone beam, you discover that they will need bone grafting. So decortication is not going to be enough. You have to open a flap and put a bone graft. But if you have thick cortical plate, yes, you will go deep. If you have thin one, because you don't want to keep going to penetrate the soft tissue from the other side. That's why you have to know how thick you can go. But usually, the other thing is we leave the crest of the bone intact. And we don't start decortication at the crest of the interdental bone. We have to leave 2 millimeters of bone coronal to our margin of decortication, especially if we're using precision. I leave 2 millimeters of the interdental papillary bone intact, interdental bone intact, coronal to the cut point, to prevent resorption of bone and loss of interdental papilla. But usually, I again take the cone beam, measure the cortex thickness, and go 1 millimeter beyond that cortex thickness. From my experience, that is enough.
Okay. I think that's the last question. What do you advise to manage very thin buccal alveolar bone around canines after the day of orthodontic debonding?
Well, I have to see the case to know what exactly I'm looking at. But usually, if I can see like the case I showed, if that's what you mean, let me share. I'm worried that you are asking me something like this, because this one to me, let me see this one. You see this one? You see this image?
Yes.
This is not really, what I'm looking at is not bone. What I'm looking at is root. So canines are very, very challenging, because sometimes orthodontics exaggerate the expansion, especially for impacted ones, and end up with the canine outside the alveolus. And those are really, really difficult to get back into the alveolus. Those cases probably would definitely need decortication to allow them to be brought back to the alveolus. So usually when I'm